So I want to share with you today a couple of things that, one, is very important to you all as plastic surgeons or robotic surgeons, and the other one will be important in the future. The first thing is, I want to share with you the pivotal role of precise perioperative fluid management and hemodynamic optimization for high-risk surgical patients undergoing microvascular surgery and plastic surgery in order to really minimize potential complications such as obviously poor perfusion to a free flap or a leak of any anastomosis, either an organ or a microvascular anastomosis. And obviously this is guided by new technology that we have at our fingertips that allow us to really tailor fluids in a beat-to-beat manner, non-invasively, and be able to manage hemodynamics very precisely intraoperatively. And the other thing that I want to share with you is what we're doing at MD Anderson, which is the combination of the enhanced recovery pathways with robotic surgery. So I'll show you the benefits, what we've seen so far, decreasing costs, decreasing lengths of stay, maximizing patient-reported outcomes, which is very important in the United States right now, and obviously assisting our fragile healthcare system, minimizing the costs, and ultimately helping tackle the opioid epidemics. We spend $70 billion per year in the United States really with opioid epidemics, and we're trying to tackle this problem, which is one of the nation's leading healthcare preventable problems. This is the medical center. Let me use my pointer. This is the mecca of the medicine in the world, considered by many. Not different in size from downtown Houston and not far away, where we count with the largest congregation of Da Vinci robotic units in the world. We currently have 30 of them, and 4 are being routinely used at MD Anderson. Reason why we have our surgeons' tremendous experience in robotic surgery. As surgeons, the important thing to understand in anesthesia is that for fluid management, not the endothelium, but the glycocalyx, the real molecular filter that allows plasmatic protein filtration, maintains the oncotic pressure, and forms the functional layer of the endothelium. This is extremely important. As you can see here, there is a nice, elegant relationship between this glycocalyx and the vascular lumen. This is a microelectroscopy image. In a closer view, you can see these hairy particles that are glycoproteins that are really on top of the endothelium, and that's very fragile in microvascular surgery, any surgical trauma. So this is extremely important for 2 reasons. One, Frank Starling, which you're familiar with, was not familiar with this tremendous anatomical barrier. So his principles should be revised and updated. And 2, Chappell and co-workers have clearly demonstrated that the third space doesn't exist. It's a pure architectonic invention from the surgeons, specifically the trauma surgeons and the GI surgeons, but its existence has never been elucidated in the literature. So that has revolutionized the way we manage fluids intraoperatively. You can see the bottom image is a total destruction of that architecture. This is what leads to only one space where the fluid goes, interstitial edema. And what happens is that the distance in which the molecule of oxygen is to travel to the cell to supply oxygen for your tissues, which is short, now the gap is much wider. So that leads to tissue hypoxemia, apoptosis, cellular death, and that's sometimes what you think as surgeons surgically explain failure of a free flap or vascular anastomosis. 2 things in anesthesia cause this: under administration and over administration of fluids. Once the damage is done, it's unstoppable. There is a massive release of inflammatory mediators, the coagulation cascade, cytokines, clotting factors, inflammatory mediators that really have been shown in the literature to increase morbid mortality in patients undergoing major elective surgery. What about microvascular surgery or complex plastic reconstructive surgery? Flaps, as we all know, the flaps that are transferred for many of these procedures are denervated. They lack lymphatic system. They have a very sensitive glycocalyx, so they're really prone to interstitial edema. 2 things we always must think as an anesthesiologist in your operations. One is, the most important thing is not the pressure, but the blood flow and the delivery of oxygen to the tissues that are at risk under surgical trauma. What about blood pressure? We cannot assume that perfusion is adequate with a normal blood pressure. Why? Because during hypotension in the operating room, in any of these cases, the sympathetic system releases catecholamines, norepinephrine, you have vasoconstriction, or even worse, your anesthesiologist give probably one of the worst medications that you don't like, which is alpha agonist, phenylephrine, and that causes a massive peripheral and splenic vasoconstriction that what you see in the monitors in the operating room, it's a normal to marginal pressure. However, blood flow and perfusion are reduced, and this is what causes trouble. This is what leads to tissue ischemia and unexplained failures in some procedures. Hamilton and co-workers were clearly demonstrated that they removed 20 to 30% of blood volume in totally healthy volunteers, and they found that the arterial blood pressure did not detect any changes. So the pressure didn't change at all. However, when they inserted the gastric tonometer, that is a very sensitive tool to detect tissue ischemia, they all develop ischemia. That tells you a lot, just so you get an idea that blood pressure is not a good indicator of perfusion or volume status. I'm going to show you a quick video. If I can play this, yeah. What you see in the operating room, this is the typical. A line gives you a systolic, a diastolic, and a mean. Doesn't tell you anything else about volume status, if your patient needs more fluids or not, or where are we standing on that. Versus now we have available technology, non-invasively. We don't use A lines anymore for these cases, in which including thoracic, gynecologic, urologic, robotic surgery, and plastics, in which you can see cardiac output, cardiac index, stroke volume, and really infer the delivery of oxygen right at the level where the surgeons are operating. This is extremely important for us, and really has revolutionized one thing that will be the scientific evidence, that we are not more liberal with fluids. It's better to be restrictive, because liberal fluids lead to trouble, like these two guys are going to be before they get home. A little bit of data. This is a study from TAN. It's a retrospective study from Switzerland and New Zealand, I'm sorry, and it's a retrospective study looking at the input and output in the first 48 hours after plastic surgery. I was astonished by this. 43% of the patients, almost half of them, have over-administration of fluids and interstitial edema. 10% develop congestive heart failure. This is unacceptable. This is what leads to expenses in healthcare system, complications, and increasing morbid mortality. Another from the laryngoscope in 2010, what makes a good flap go back? You'll see always the same in the literature. More than 7 liters of IV fluid administration. This is very common. These procedures last 7-8 hours. Most people end up giving a liter per hour based on weight and urine output and heart rate. Those parameters are very insensitive on letting you know if the patient needs or not fluids. Another paper from the group of Toronto, Clark, predictors of morbidity following free flap reconstruction for cancer of the head and neck. The same thing. Hemoglobin, not only low because of chemotherapy, but always remember that as we administer fluids and you don't have significant blood loss, there is dilutional anemia leading to transfusion, and we all know the negative impact in the immune system in cancer patients when we transfuse them. Also the same administration of fluids. So as you can see in this bottom image here, illustration, this is the x-axis is the volume status, y-axis is morbidity. As soon as we move away from this perfect state of euvolemia, normal homeostasis, where the patient should be intraoperatively, you see increasing complications, obviously from hypoperfusion or over-administration of fluids, anastomotic leak, ileus, etc. And from this side, obviously ischemia of a flap can be, for example, or poor perfusion, or even worse organ injuries such as acute renal failure, etc. So how do we do this? Well, now we have technology at our fingertips in the United States, in Europe, and I think globally now, where you can have immediate information, beat to beat, and very reliable. This has been already compared and validated against the PA catheter, the Swan-Ganz catheter, where you can have parameters of blood flow to tissues which are very sensitive indicators of volume status. I wanted to show you our elegant model, and Dr. De Bocard tried initially the technology, one of the technologies, and then he got more serious into it and excited and checking his pressure. And I'm glad to see the surgeons enjoying things that we can also share to your practice. This is just to show you that we use it in pretty much every case. In gynecologic surgery, urologic prostatectomy, all robotic, thoracic. So we have the largest number right now in the world of thoracic cases without an arterial line. A robotic lobectomy, about 500 of them with just this kind of technology. You don't need to take 45 minutes putting an A-line, and this gives you more information. We already know what to expect. This is one of Dr. Silver's case on plastic surgery, protecting the technology so there's no injury to any nerves in the arms. But what is important is this technology allows you to early detect hemodynamic derangement and predict where the problem is, the harm, and attack it immediately. Obviously, technologies don't save lives. We have protocols. We have really worked hard with surgeons and ourselves, elaborating these intraoperative and post-operative protocols for fluid management. So now at MD Anderson, if we're 50 anesthesiologists, nobody can give the fluids however they want. Because as you know, in your hospitals, there's a lot of variation between anesthesiologists. Now we're protocolized. You know, nobody they're doing the right thing, and we're already about to publish a couple of papers on decreasing acute renal failure and costs. Now I want to switch gears a little bit to what I wanted to share about the combination of enhanced recovery programs and robotic surgery. This is the cover from Fortune magazine in last year. Humans are underrated, that is true, we all know that. And the robots and artificial intelligence are here to stay. They come at a cost for society and healthcare. So we have to think about ways, at least in the United States, how to not jeopardize the future of robotic surgery due to cost and healthcare. How do we work together to make sure that we minimize the impact to our fragile and suffocating healthcare system? So you guys have already demonstrated that you have better outcomes with robotic surgery, less length of stay, less complications. Now to that, we have evolved the anesthesiology from the caveman, hammering the patients with anesthetics and a bunch of opioids. We really have come together with you all and work in minimizing opioids, using opioid-sparing techniques, using multimodal analgesia, using regional blocks. Now most of our blocks at MD Anderson are placed by the surgeons. We don't do any epidurals anymore, and I'll show you in a minute. So now all this together is allowing us to see things. Why it's important for us, as you can see in an oncologic center, in the perioperative period, it's a high vulnerable time for the patients to develop risk as metastasis. What depresses the immune system? Pro-angiogenic environment due to the stress of surgery. We know that you guys have done tremendous evolution with minimal invasive surgery and robotic to minimize the impact on the stress and the stress response. But from the anesthesia point of view, the volatile agents, the anesthetic agents, the gases, cause an effect, and the opioids, a negative impact on the natural killer cells. And so we're working on new technologies and techniques to minimize that and prevent using opioids. Another reason that is important, the leadership of our institution is interested in this combination. They want to support this, and we want to make sure that we accelerate patient functional recovery and pave the way in the United States in this arena. One of the important things is, this is a term we copyrighted there, which is return to intended oncologic therapy. As the patients get better from robotic surgery quicker and all this combination of enhanced recovery pathways, they're gonna come earlier, and they are coming earlier. There's a data from the gynecology group earlier, 2-3 weeks to chemotherapy. That will be linked to survival in the future. We need, obviously, many cases to be able to tie to survival. What is multimodal analgesia? Just using different pharmacologic agents that work in different mechanisms of action, bombarding pain basically from every front, not giving opioids or minimizing the opioids in some of the surgical procedures. All of our patients receive in the morning of surgery gabapentoids, Lyrica or gabapentin, tramadol by mouth with a glass of water, and everybody's getting now COX-2 inhibitors because they have not been proven to be really deleterious to the heart anymore. There's data, so we use it because they have less effect on the platelets, so less bleeding for you all in robotic surgery, and also as well less effect on the kidneys. Everybody gets intraoperative administration of Decadron, a potent steroid, as an anti-inflammatory effect. And the goal is to block all of the descending and ascending pain pathways. So we basically don't give much opioids. We're fortunate in the United States, All of our surgeons are using now liposomal bupivacaine. I know it's gonna come to Europe very close, probably under another name, but it's a long-acting local anesthetic that sits after the surgeon's injected in the infiltration area and close to a nerve. Whatever they do, it sits for about 3 days. So that helps us also minimize opioids. I'm gonna show you a little video of how we did it in thoracic surgery. We published this and we got rid of the epidural. You can see here, this is where the epidural space goes. We go about 5 centimeters from the spinous process. This patient is in the lateral decubitus. The surgeon is injecting a thoracoscopic 5 millimeter scope, and we mix the expert with methylene blue. So he's sitting from behind the surgeon and injecting with a 20 gauge needle all the way until you see the tenting on the pleura right there, and deploy this local anesthetic that sits for 3 days. That is the only way we have been able to see a marked decrease in opioids. You know, it's an exact deployment of that medication in the pathways. I don't want to bore you with more of that video, but the good news is that we were able to demonstrate that, you know, it works the same as a thoracic epidural. Thoracic epidural has complications. So at MD Anderson, we used to be 100% thoracic epidural 5 years ago. Today, 1% thoracic epidurals. All are the blocks done by the surgeons in robotic lobectomies and also as well in thoracotomies. We're able to recently demonstrate that there's an 80% reduction in perioperative opioid and morphine equivalents. So our patients, you can picture this as surgeons, our patients are going home with Tylenol over the counter and ibuprofen. No narcotics. I told you already, we have a tremendous opioid epidemic in the United States. There's addiction, there's misuse, this is extremely important. We were asked, we're probably going to send that to JAMA, and I think it'll be a great contribution to society. We're refining that. But what really has helped us a lot working as an anesthesiologist at MD Anderson all these years is that it's an evolution. You know, the anesthesiologist 20 years ago was a physician dedicated to really maintaining optimal conditions for the surgeons in the operating room, and today we have come together in a collegiate environment, worked as partners and figured out ways to help our healthcare system and do research. Dr. Selder and I are working on probably the first randomized controlled trial, am I allowed to say that? Sure. In the United States, in trans, a conventional way, one arm, and the other arm in a enhanced recovery pathway. We should be close to IRB submission. And this is one of the most important things to finalize, that what we're thinking. We know that the current healthcare model in the United States, which is fee for service or unbundled, there is more quantity of procedures, less quality of care. We all already know that. This is a problem because we have a fragile healthcare system and they're going to be scrutinizing the cost of the robotic technology. That is obvious. How do we help that? How do we overcome that? We're doing a comprehensive cost care analysis. We're trying to combine, as I told you earlier, the ERAS or enhanced recovery programs with minimal invasive or robotic surgery, tie this to the patient-reported outcomes that are very, very important, and this will be important for the payers and insurance companies once we get to the bundles of payment. How do we do that? The only way to demonstrate that is that all the astronomical costs from the robot in the first day of surgery can be offset by decreasing more lengths of stay, less conversion to open, minimizing complications, readmissions, surgical site infections, and obviously demonstrate the leadership of the hospital that we can increase revenue of the hospital at the institution. Dr. Silver showed this yesterday, and if you have a patient with a lobectomy that stays, instead of a week, 2 days, you have 3.5 patients room lobectomies per week, so you triple your revenue. And this has been extremely important for us. This could be the future to healthcare or helping healthcare in the United States. And this is just to finalize. I wanted to share, it's one of my favorite pictures, one of the enhanced recovery program patient in thoracic surgery, robotic lobectomy, left lobectomy, 48 hours after surgery, pedaling on his bicycle with a chest tube. And these are the things that are really gratifying and allow us to share with you that we really are paving the way in the United States in this arena. Thank you.